All right. Good morning, good evening, everyone. I think we can get started. So, today's conversation is with Dr. Pranjali Gadgil, and very, very excited about it. Let me cover a few quick housekeeping notes and then we can uh, get going. All right. So, as always, just stay on mute and type away your questions in the chat window throughout the session. We'll get through as many of them at the end. Uh, for those who are not already part of the longevity lab, here are some of the reasons to be a part of it. It's completely free. If you want to engage, just take a screenshot of the QR code, and that will get you into the WhatsApp community where you'll be kept up to date. But the one thing you can count on is every Thursday at this time, which is 9 o'clock in the night, India time, 8:30 in the morning, US time, we have a session like this one. We take snippets of the session. We have the full session, the snippets of the session, the PDF notes of the session, all in the community. And so if you're a part of the community, you get all of this. Even if you miss the session, you can watch it later. And many of you have come here because of my blog post. And for those who are not, you can go to Substack and get it there from there on with my full name. All right. The one quick community feature that I want to introduce today is starting tomorrow, every day I'll be posting in the community a 1-minute video on a topic that I think you will find interesting, useful, and more importantly, actionable. So I put some examples here of topics. They're only 1 minute long. At the end of 1 minute, you'll at least have some new insight that you probably may not have had before it. A couple of things that we've already introduced, and I just want to remind everyone is if you have a conversation on the community and you want to check the validity, the scientific credibility of any answer that has been provided, or you've heard something somewhere in some social media and you want to get that clarified, just add moderator Kai in your message, and the account will jump in and provide a response to your question. And if you want to see playlists of previous content, whether it's the full form of the content or just snippets of it, they are pinned at the top of the WhatsApp group community circle. Right. For next week, the speaker is going to be Dr. Lauren Kelly Chew. She is someone who works a lot in understanding metabolic health. She's an MD by training, but she's worked at some of the biggest preventive health, precision medicine companies, whether it's Google's Verily division, Levels Health, which was sort of the pioneer in the whole area of continuous glucose monitoring, and now she works in the area of lung cancer. She's going to we have a very exciting conversation planned for next week. So keep that on your calendars. All right. So I want to introduce today's speaker, Dr. Pranjali Gadgil. Pranjali, I've known for a while now, and I'm now going to go through everything she's done. But what we have on the screen is just sort of a subset or a snippet of what her background is. She's very, very accomplished, and as importantly, she's a wonderful human being. And so I want to provide some quick background as to what the rationale behind this session is. This is a deeply personal topic for me. My mother passed away from breast cancer at the age of 69. She was diagnosed at stage 2, so it was pretty early. And looking back, and I truly believe she might still be with us today if a few things had been done differently, both before her diagnosis. So what could she have done differently if we had known better? And certain things could have been done differently during her treatment. And I would say her journey is one of the main reasons I entered this healthcare space. And as I began to understand the whole system more deeply, I came across a statistic that has stayed with me. and that is the 5-year survival rate for breast cancer, which is from the time you were diagnosed, 5 years later, how many people survived. The 5-year survival rate for breast cancer in India is around 66%, while that in the US is closer to 89%. And what this basically tells us is that 23% of women in India who are diagnosed with breast cancer don't make it. But had they been in the US, had they had access to earlier detection, better support, different care pathways, they would have still been alive. And this is not just alarming, it's unacceptable. Today actually marks this week actually marks the 7th anniversary of my mom's passing. And in her memory, I've invited Dr. Pranjali Gadgil to speak with us, because she's someone I wish I had known earlier in my mother's journey. And I truly hope her insights today help prevent other families from going through what we did. And I know there are many breast cancer survivors even on the call today, and that gives me hope. But there is still so much work to be done. And whether it's an awareness, action, access, and my goal, and maybe perhaps even my obligation, is to help reduce the chances of more stories like my mom's. So without further ado, Pranjali, welcome to the community
Thank you.
longevity.
Thanks for having me here. And it's a privilege to have known you, your family, your mom at some point. And hopefully today we pass on some messages to someone somewhere out there who's going to benefit from it, right? So our job is to put accurate evidence-based information out in the ether and hope it reaches someone who will benefit from it. So I'm looking forward to the session. Thank you.
Absolutely. Great. So Pranjali, let's start, with the basics. The numbers around breast cancer are actually quite staggering. It is the most common cancer amongst women in India, and more than 216,000 new cases in 2022 alone. And the statistic I read is 1 in 4 cancer cases amongst women are breast cancer. And in the US, those numbers are equally jarring. What's the root cause behind all of this? Is it genetics? Is it our lifestyle? Is it environmental? Is it what is causing all of this?
So when it comes to cancer, whether it is breast cancer or any other cancer, you have to think about cancer as an accident at a genetic level happening at a cell level. And so in theory, each breast cancer is actually genetic. Unless there is a genetic mutation occurring at that one cell point, you're not going to get cancer. So yes, all cancers are genetic from that standpoint, but not all cancers are hereditary. So yes, 5 to 10% of all breast cancers are because of mutations that we've already inherited at birth and are born with, and those make us particularly more susceptible to cancer. So in the rest, though, like when we say 85% of these breast cancers are sporadic, they are not, we didn't inherit any breast cancer genes, but still women get it. Then we are sort of looking at, okay, what are the lifestyle factors and what are the environmental factors? And we do know some of these as increasing risk. But the reality is also, one point we don't often talk about is that a lot of breast cancer is simply bad luck. And this, as a scientist, it sounds very callous or, not getting into it. And when I say, oh, it is bad luck. But if you think about it, our bodies are made of trillions of cells. Each time a cell divides, your probability of actually having a gene mutation is almost like you form 1 to 3 gene mutations anytime a cell divides. And most of these most of these genetic mutations are insignificant. They occur in some part of your DNA where it really doesn't matter. So a lot of breast cancer patients are simply on the luck side of being on the wrong side of the statistic, like your DNA is somehow lost out on a bad day at a casino. I mean, that is the reality of it. And so what I'm saying is, it's not that we can't control the risk factors, we can modify them, but in reality, nobody is immune to breast cancer. And as humans have evolved to fight plagues and famine, cancer is one of those things that we expect to see more and more as we outlive, our previous generations, and it comes to heart disease, we live longer to have more of those genetic errors. So it's unlikely that it's all going away in the foreseeable future, but it's something that we need to learn to live with better, combat better.
So, given what you just said, Pranjali, it sounds like on one hand, medical advances have made us live longer, which means the probability of these mutations happening that affect the wrong part that we don't want it affecting go up. So are there anything that anyone can do from a lifestyle perspective to reduce the probability of that happening?
Definitely. And when it comes to risk factors, yes, there is no vaccine we can take for breast cancer yet. So nothing is 100% preventable. But when we look at, if you look at women who have a lifestyle which involves moderate exercise at least 3 times a week, or when you're looking at women who have a diet that is higher in fruits, vegetables, legumes compared to fatty meat-based diets, you're going to see lesser breast cancer in the group that does exercise, does have a healthier diet, is maintaining normal weight. And so I think the biggest thing you can do today to decrease your breast cancer risk is maintain an active lifestyle and exercise. And we see about 20% less breast cancer in women who do have an active lifestyle and exercise.
And what would you define as an active lifestyle, Pranjali?
Yeah, if you ask in my patient clinic, when I ask women, like, do you exercise? And most women will say, yeah, I go for walks and I do a little bit of yoga in the morning. And I have to respond to that acknowledging, well, those are excellent activities and please keep doing that. But that is not exercise, like when it comes to moderate exercise, and you have to kind of go back and redefine exercise for a lot of women. It raises your heart rate and it makes you a little bit tired and you do perspire. And that is exercise. So you need to be doing something like jogging and running and swimming and playing a game of tennis. And that is moderate exercise, which actually decreases your breast cancer risk.
And a lot of what you just spoke about is mostly on the cardio side. We talk about from longevity perspective, for other reasons, strength training is critical. Does strength training play a critical, important role in breast cancer?
Strength training has also shown to decrease breast cancer risk.
Right. How much does we keep reading about environmental factors, which are not always in our control? I mean, we live where we live, but which of those environmental factors play the biggest role in impacting the breast cancer rates?
What you said is right. Like, we do have studies which have shown that, adolescent girls who have been exposed to DDT in around teenage and puberty have a higher risk of breast cancer after menopause. And that is there. I mean, if you include environmental factors, as even our diet is partly influenced by what we are eating and what is being served around to us, even that is a big environmental factor. Like obesity around teenage is an environmental factor, like, because that's what's coming to us and that's what we are feeding our kids. But yeah, I mean, the problem with environmental factors is very hard to measure. Like none of us can say how many diesel fumes we've, like respired today and how much of pesticide we've eaten today or inhaled today. And hence it's difficult to implicate. But environmental factors are definitely associated, but it's very hard to implicate and eliminate them.
And specifically things like processed foods. Is there now been enough studies to show a linkage between increased processed foods and cancer? I know it's been shown for heart disease.
And these are all.
I was saying that it has been shown for heart disease to be very directly correlated. Has there been a similar link for cancers?
In cancers, it's mainly, population-based studies, which are usually confounded by other data. So if you look at women whose population, a population of women who have a diet traditionally rich in fruits, vegetables, legumes, compared to processed foods, meats, fried foods, you do see lesser breast cancer in women who would follow a healthier diet, and it would be common. So fortunately, we don't have to prescribe different diets for cardiac risk versus breast cancer risk. It's all the same. So the diet, I mean, you've got to do what you can, and that's for multiple reasons and not just cancer.
Got it. And the numbers seem to suggest that the cases of breast cancer are only going to go up over time. But the lifespan is not increasing that dramatically. So is this increase in the number of cases a case of just more people are getting diagnosed who otherwise would not have been diagnosed? Or is there something actually happening that's causing the rates to go up?
I think it's a combination of both. So if you look at generational risk, once upon a time, it was acceptable 100 years ago for an elderly person in the family to, suddenly we realized that, okay, they're not eating as much and they stopped eating and they passed away at home. And yes, maybe they had a lump at that time and nobody looked at it. It's that is over the generations true. But even if you look at recent data, like if you look at data from 2019 to today, nothing has dramatically changed, but yet every year we are seeing 1% more increase in breast cancer, even in societies which have been screening since the 80s. And you're seeing that increase not just in women who are older, like over the age of 50, but also in younger women. So you've got to then assume that there is factors in our lifestyle as well as environment that are making that difference.
Is there anything, I mean, I know this is a tough question to ask, but if you could point to 1, 2, 3 things that you think are the biggest causes of it that's sort of changing year to year for this 1% increase, what would you point the finger at?
We see a lot, even in India, as we replicate the West, we see more postmenopausal breast cancer associated with obesity. And so I would say the one thing we can control, and we know it should be healthy lifestyle, maintaining a normal weight, and that's going to have long-term benefit when it comes to this.
You brought up the topic of postmenopausal women, and it gets that much harder to maintain healthy weight because of all the changes. How do you speak to someone who's going through menopause and all the issues that come with it, and sort of get them to control weight, which is a pretty hard thing to do at that age because of that stage of menopause? How do you deal with those women?
So there's actually a whole society now we have like an Indian menopause society, a whole society of doctors that specialize in management of menopause, because it is a very complex issue. As a breast cancer surgeon, it just happens to be the time around which we have already just started screening women. We usually recommend starting screening mammography at the age of 40. So a lot of women coming in have a lot of overlapping symptoms. Even when it comes to breast disease, they have menopausal breast health issues, and then it's also the time you're starting to screen for breast cancer. And when it comes to modification of risk factors, what you realize is a lot of women blame weight gain on menopause, but sometimes it's not just the menopause itself, but there are associated issues that sometimes are getting unrecognized. So you may find that, okay, you're gaining weight because you actually have a thyroid issue. Your metabolism is changing, and you're keeping your diet and activity levels the same as it was before. So to actually accept the change and modify things to now meet your new body needs really of that time is something a lot about that takes a little bit of acceptance and counseling. And I can't say that I dedicate a whole lot of time in my regular oncology practice doing just that, but I do refer to my colleagues who actually specialize in menopause.
That's actually a pretty useful piece of information. This is an area that has been evolving, and I think we've spoken about this in a previous session where this 2002 Women's Health Initiative study really messed up and took all the studies around menopause backwards. And now, even in the US, they're trying to catch back up. But the fact that in India, there is a menopause society and there are doctors who are trained in that, I think that's great. Is there link, Pranjali, we can get from you later on that we
Yeah,
can
there
share?
is an Indian Menopause Society. I'm a member of their Pune chapter, and they do include multiple specialists on some of these events they organize for doctors, as well as they do see our patients specifically for menopausal issues, and mainly it's a subset of the oncological groups like the FOXY and POGS, which exist in India.
Okay. So maybe Pranjali will get from you later on a
Yeah,
link to that thing
I'll
so that
share.
we can put it up on the community. Going back to the genetics, the genes, there is, and I think maybe Angelina Jolie made this whole thing well known, the BRCA1, BRCA2. Until then, scientists knew it. Then suddenly everybody knew it. Uh,
Yeah.
and I remember the statistic was quite confounding for the common man, which is, I think the risk, and you can correct me if I'm wrong, Pranjali, if I'm saying this wrong, but the risk of the typical woman to get breast cancer sometime in their life is about 12%, but for someone with the BRCA1, BRCA2 mutations, it's 72%. However, out of the women who do get breast cancer, less than 10% actually have that mutation. So that means it's that gene plays a role, but there are non-genetic roles, reasons why people get breast cancer. Is that right?
Yeah, most of those numbers are correct, and it's only the difference being that the incidence of breast cancer is not as high in India when it comes to the 13% number is closer to is about the Caucasian populations and not the Indian population. Although that's not something to be proud of, because although we see half the number of cancers that the US does, we have twice the number of breast cancer deaths in India. But you're right about the genetics. I mean, 5 to 10% of breast cancers, we say, are because of known genetic mutations that we can actually implicate in having caused a woman's breast cancer when she comes to us. When you are a carrier of some of these major genetic mutations, like the BRCA1 and 2 and PLB2, we say the lifetime risk of developing breast cancer can be as high as 40 to 60%. And that varies based on what age the person has already made it to, what are their competing mortality risks, and so on and so forth. So it's not that all 70% of women who have the BRCA gene are going to get it, but it's the lifetime risk is way higher than the average woman. So these are the patients now. I mean, it's not simply about Hollywood and Angelina Jolie. Even in Pune, we have quite a few women who are asymptomatic carriers of these genes who do elect to undergo risk reduction with prophylactic surgeries like a mastectomy with reconstruction. And what was I going to say? Anyway, yeah.
Got it. And so, what is your recommendation? Because I have now run into both types of people who say, if that's true, I want to know whether I have that mutation. And the second group who says, look, if I knew it, I would just be worried. Instead, I'll just do whatever I'm supposed to do, assuming I have it. And I see there's, both sides have their own viewpoints on it, and there's no point trying to convince one of the other. But how do you deal with people who, are in a situation like this?
So when it comes specifically to the BRCA BRCA test, BRCA1 and 2 genetic mutations, or the hereditary breast and ovarian cancer panels that we do for genetic testing, these are not recommended for general population screening. So it's not like, okay, my annual health check, I do a hemogram or a blood sugar level, I'm going to include a BRCA test. That's not what is recommended, because the incidence population wide, I mean, we say, yeah, 5 to 10% of all breast cancers, but population wide, if you started screening people, the incidence is actually less than 1% of your likelihood of finding a BRCA mutation. And even in patients who meet criteria for testing, so as oncologists, we offer testing to our breast cancer patients who meet certain criteria for testing. And now we can talk about what those criteria are later. But specifically breast cancer patients or family members who have a high risk history where, you have multiple family members on one side of the family either on your father or mother, biological parent side, who have had breast, ovarian, pancreatic, prostate cancers on one side of the family, especially young cancers, multiple cancers in the same individual. And there are certain specific criteria that an organization called NCCN recommends we use for testing. Now, that being said, these criteria are used mainly to select out patients for testing where there is a third-party payer system to justify testing. But now what we've realized is, especially when it comes to breast cancer patients, we were using these criteria selectively, and now we become more liberal about the use. Because if a certain patient says that, even if my probability of having this gene mutation is 2-3%, and I want to know, can I do the test? And they're paying for it, and they're willing to undergo the counseling. So no test should be done without pre-test genetic counseling, because these tests are complex, the results are difficult to interpret, and it's not appropriate to do a test unless you know how you're going to utilize that information. So to bring to about your point of whether it's simply curiosity and anxiety provoking, that's no longer true, because now you have methods of mitigating risk in a gene mutation carrier. That being said, it's still a very, the solutions that oncologists have today, whether it is a preventive mastectomy, which it's a more acceptable solution today because we have advanced methods of breast reconstruction. So it's more or less like undergoing a breast replacement surgery so that your genetically inherited breast tissue that is there in your body, which is mutated, let's get rid of some of it so that your risk of developing breast cancer, whatever it is, that 60% risk is reduced by 90% of what that was. So not gone to zero, but still you're achieving a significant risk reduction to where now your risk is almost the risk of an average woman when it comes to breast cancer. And of course, these women also recommended to undergo removal of the ovaries and fallopian tubes because they're at high risk of developing ovarian cancer as well. But every genetic test needs to be accompanied by a very thorough genetic counseling appointment. And that's an interview where, we evaluate the patient's family history, we study the pathology reports in the family, advise who's the right family member to be tested first, and then suggest, well, how are you actually going to utilize this genetic information to mitigate your own risk if you were in fact a carrier. So there's a lot evolving in this space, and so anybody who's dealing with family history is usually advised to first come in for a counseling appointment for that.
Yeah, and I want to just reiterate that point for everyone on the call, and that is the importance of counseling can't be understated. And what's happened is, when companies like 23andMe came into the picture, you could get all of this information without any counseling. And the number of people who started getting nervous because there was no counseling done, and now it was left to them to interpret what a 17% chance of getting a disease is, how to think about it. And so I think this is a very, very critical point, that if anyone is considering any form of genetic testing, please make sure that wherever you're doing it, it is accompanied with a pre-test counseling.
Yep.
All right. What are the most important early warning signs, Pranjali, that people tend to ignore?
This is, you could read 10 signs off of the internet that are signs of breast cancer. And you would think that nobody would ignore a sign of breast cancer. Like if you felt a sign, you would go see a doctor. The problem is that breast cancer is also a big masquerader. Like a lot of non-cancer breast disease and breast cancer look very similar. For instance, like let's say you have a woman who is breastfeeding and she has a lump. The most common assumption is, it's probably a milk collection. It's probably an abscess or an infection related to breastfeeding. But that could just as well be pregnancy-associated breast cancer. A woman has a rash around the nipple, and that could just be an eczema, but it could also be a rare disease called as Paget's disease, which is a cancer of the nipple. Now, you could have a woman who simply has redness and warmth of the skin of the breast, and that's most commonly mastitis or breast infections. but it could also be inflammatory breast cancer. So the problem is this, and this is not just true for women, it is also confusing for clinicians who do not have a large experience in treating breast disease and breast cancer. So I think it's very important that if a woman notices anything unusual, she not try to read too much into it. So we find that women sometimes have had a symptom for 6 months. And when you ask them, you've had this lump for 6 months, and she says, no, it wasn't really a lump 6 months ago. It was just this hardness in one area of the breast, and the skin got a little thicker. And when it got red and it got a little ulcerated, I applied some ointment. I thought it was better. So they keep justifying to themselves why whatever symptom they're feeling is actually not cancer. So it doesn't matter how trivial it seems, doesn't matter that it doesn't hurt. If you notice something unusual, and it could be a change in the shape of the breast, puckering of the skin, a lump in the armpit can be a sign of breast cancer. So it's not always a swelling or a lump. It could be abnormal nipple discharge. But again, you can get nipple discharge without having breast cancer. So anytime you notice something unusual, it's important to see a breast specialist. A lot of times women don't know who to see because they think, oh, should I go to a cancer surgeon because this may not be cancer? Should I go to a surgeon? I may not need it removed. Should I go to a gynecologist? But it doesn't really come within the scope of a gynecology practice. So to make it simple, I'm a breast cancer surgeon, but I practice as a breast disease specialist. So if there's a breast problem, go to the breast doctor and let them figure it out. The more important thing, though, is we don't have to wait for symptoms to develop. So in the early stages, there are no symptoms and there are no signs. And the best stage to catch breast cancer is at the time there are no signs. And the only really proven way to do that is to do an annual mammogram once you're over the age of 40. And that's recommended for all women.
Actually, Pranjali, I want to get to the testing next, but I want to go back to on a related topic. With breast-related things, you can actually observe at least at times because it's visible. Ovarian cancer, on the other hand, with the ovaries, there is no such visibility. And the number of people I've known who were diagnosed with ovarian cancer almost always happened pretty late. How do you sort of advise?
So, ovarian cancer incidence is not as high as breast cancer. So it doesn't come into regular population-wide screening programs, even in countries that do have screening. Now, in women who are BRCA mutation carriers and do have a higher risk of developing ovarian cancer, and can be as high as 40 to 60%, compared to breast cancer, where not every BRCA mutation carrier needs to undergo a preventive mastectomy. They can elect to undergo high-risk surveillance with alternating mammography and breast MRI. But for ovarian cancer, we really do encourage women that after the age of 35 or after you've completed family to undergo a preventive salpingo-oophorectomy or removal of the tubes and ovaries, because the ovaries are way deep inside, and by the time you develop any symptoms from the disease, you do end up having stage 3 cancer in many patients, in majority of patients. So.
Yeah. So at least my takeaway from this, Pranjali, is when it comes to breast cancer, err on the side of caution, where if you see a sign that seems off, don't keep waiting for it to go away. Talk to a breast specialist, right? For ovarian, if you are a carrier of the BRCA1, BRCA2 mutation, after the age of 35 or after you've had your family, seriously think about preventive getting rid of it.
And that's usually a laparoscopic, a daycare type of surgery. So it's not a very morbid surgery to undergo it either.
Okay, great. That's actually very, very practical advice, very actionable. Going back to testing, you spoke about the annual screening. What are the different options and what are the different things a woman should do as part of the screening?
So let's talk about the average risk woman. We're not talking about BRCA mutation carriers here. But after the age of 30, once a year, get a clinical breast exam done by your physician, gynecologist, breast surgeon, whoever is your clinician you trust and are comfortable doing a breast exam with. Once a year, they need to do a physical breast exam after the age of 30. And then once you're 40, at a baseline, get a good quality digital mammogram. In the US, almost all centers do offer what we call as full field digital mammography with tomosynthesis, which is like a 3D version of the mammogram. And it does have very high sensitivity, good quality imaging. In India, there are still a lot of centers which are using poor quality, old, poorly calibrated equipment to do mammography. They end up not doing the mammogram right, end up calling patients back for an ultrasound. The patients get very confused. I was asked to do a mammo. They called me back for an ultrasound. The quality of reporting, because we are not primarily a screening country, the volume of normal images that an average radiology center sees is very low. So the experience of reporting mammography that goes hand in hand affects the quality of diagnostic imaging we have as well. So the quality of breast imaging in general is very poor, but we do have some very high quality, good imaging centers coming up. There is a Breast Imaging Society of India. We have qualified specialists now that are specializing in breast imaging, and centers, at least there are 8 centers in Pune which have digital mammography with tomosynthesis. So there are women do have options, but they don't realize that it's really one mammography center is not the same as the other. So if if you are undergoing mammography, you need to do it at a good place in a reliable setup where there are good technicians, good equipment, good radiologists who are comfortable and have a good volume and expertise of reporting breast imaging.
And Pranjali, is there a list like this, a directory of the ones that are considered good? Because I'm sure there's a directory of all, but the ones that are good, is there somebody who verifies, validates them?
Well, for my patients, I tell them where to go, and I can share that with you because I want to. If you're going for a mammogram, do a good quality mammogram. So.
Yeah, no, I think
I would look for full field digital mammography because a lot of people, they're offering analog mammography using what we call CR systems to then digitize those images. It's kind of like uploading your grandmother's old film, like a picture, onto the computer and calling it a digital image. But it was never acquired digitally at that high resolution. And the same goes for digital mammography. So the image acquisition technique varies from one mammography center to the other. So look for full field digital mammography is what I would say.
so. What we are going to do is in the show notes, we'll put this specific point you made, but we'll also take from you, Pranjali, the places that you recommend, because at least at a minimum, it'll give people a sense for where they can go. In the US, I think it's easier because there are quite a few good places. In India, we have to be picky.
And we don't have an equivalent of like a NAPBC accredited breast center or anything like that.
Yeah. One of the things that has come up in the US has been this whole Grail, the gallery test from Grail, right? And I'm sure you're very aware of it. I know it's not available in India.
It's not available in India, so
right.
I'm thankful for that.
But so can you talk about that? Like, if it was available, or if somebody from India is going to the US, would you recommend they do it, or would you recommend they not do it? And what would be the reasons for either?
Well, I think it's too early. Your false negative, false positive rates are still quite high, and you can't have a positive predictive value of 50% or less for a test that is dealing with a condition as serious as cancer. So if you're telling me that my cancer signal, but there's 60% chance that I don't have cancer, that is a lot of anxiety. That's a lot of unnecessary investigations that comes with its risks of overdiagnosis, complications from those excessive diagnostic tests. So there's a lot there. Now, I can't say we should throw away the baby with the bathwater. There's still a trial that's going on in the UK. The NHS is doing a larger scale trial to use it in screening. So I think, when we develop a big test, we expect to see big outcomes, and we expect it to be all encompassing. And I think over time it will evolve to have a part somewhere that it will be beneficial to in a certain group of patients, in a certain population for screening. And then when it does, you need to have a very crisp algorithm of what you do with the report onward. So much like, okay, if I had an abnormal mammogram, I'm going to do an ultrasound. If I have something on ultrasound, I'm going to proceed with an image-guided biopsy and then conclude that one way or the other. And that is not quite there yet with tests like the Gallery test, where it's probably going to have a role at some point in some, or it may be an entirely tangential evolution where we end up using it somewhere in cancer surveillance in specific, subpopulations. Who knows? It'll have probably a useful spin-off, but it's not there yet where I would recommend the average person to just go.
Yeah, so I can add to that. So I've written about this in one of my blog posts, and I have been following it for the last 3-4 years. And what I've been finding is that the sensitivity and specificity of the various cancers are different. So it doesn't detect every cancer at the same level of sensitivity and specificity, some better than others. And every year, it seems all the levels seem to be getting better. Today, so what I wrote in my blog post is, I'm not yet ready to do it because of the levels not getting to where I would like them to be. But I think it's getting to the point where maybe in the next year, I would be a lot more open, because at least 20-25 cancers have gone past about the 80% mark. Okay? But there are still many sub 50%, which means I might as well flip a coin and decide whether I have cancer. Right? And so all in all, I would say it's an area that's evolving. But I have not yet gotten myself to do it, because I spoke to my primary care physician about it, because she does see people who have done it. And the challenge is, if it's a false positive, you have to now spend the next 3 months doing pretty invasive stuff to prove that you don't have it.
Yes.
And the emotional turmoil is too high. I don't know whether I can deal with that. So I've not done it, but I think it'll get there at some point. I don't know when. But it's good to hear your thoughts as well on this, because this is something I'm always very curious about, how different people evaluate this. Let's talk a little bit, Pranjali, about, I want to talk about the therapeutic side of things. But before that, I know there's a topic that you have been very passionate about, and that is the role that men play in the lives of women who are diagnosed, because you are constantly seeing these types of situations. Can you talk a little bit about this? Because this is a very strong factor in how one can deal with something such a big diagnosis.
So when it comes to, my diagnostic clinic, where women are coming in for symptoms, and there's a little bit of cultural difference there, but often a woman who has pain is accompanied by her husband, because they're both distressed by the fact that she has breast pain and she has these complaints, and it's affecting their life and it's affecting intimacy, and they come in as a couple. When it comes to, you see a little bit older woman who has a lump that she's not particularly bothered about. She's probably mentioned to her husband that, oh, I have this lump, but he's like, is it bothering you? Is it, is it really something serious? And, sometimes it gets dismissed and missed a lot longer because he hasn't paid attention, because he didn't think it was serious. A lot of times men don't educate themselves about breast cancer but they are in an advisory position, and the next person, a lot of time, a woman speaks to. Sometimes there is hesitation, like if a woman has only, an elderly women, I especially see this, that a woman is 75, 80, sometimes she doesn't have a surviving partner, and then there are two young boys she has, or the two sons in the family are not somebody she's comfortable talking about this to. So firstly, I'm happy to see that we have an audience today that is a mixture of men and women, because you are in a position to influence a woman's choice about their breast health. So that's one. When it comes to I think when it comes to the treatment journey, um, you see women do very well when they have a supporting partner. But I personally, and this is totally not data proven, but I feel that women who stay in the driver's seat of the actual decision making do better. So you got to accompany your partner and be supportive and help them make their decisions, but you got to help them make their decisions. It is their bodies, it is their life, it is their choices. They need to retain a sense of of being in control, and those are, I feel, the women that do better, and I see them thriving in spite of a breast cancer diagnosis, living with a breast cancer diagnosis better compared to the woman who says, okay, I don't want to deal with this, you deal with this for me, or I will do as my family says. And I think there's a lot of socio-cultural, bigger picture programming that goes into these conversations. But I think it's important that, men help their daughters, partners, mothers stay in the driver's seat when it comes to these decisions.
Yeah. We're getting a ton of questions being posted, so I want to quickly get to them. But on therapy, so woman has, let's say she's been diagnosed, unfortunately, with breast cancer. What's the journey like from your perspective as you see patients go through this? And what are the options?
So, it's kind of a little bit like playing a game of chess. You look at your opponent's move, and then you figure out what's going to be your move, what is really the ammunition you're going to use against this disease. So a lot of the initial time that needs to get invested is in accurate data gathering about the specifics of that particular patient's tumor. So women often compare their breast cancer with, anecdotal stories of what they've heard amongst friends and family. And each breast cancer is different. Genetically, breast cancer is hundreds of different diseases clubbed under one umbrella, and we don't treat each patient the same way. So once we've studied the subtype of tumor, the stage of the tumor, the patient's own factors, like are they premenopausal, postmenopausal, what is their age, have they completed family, do they intend to have a family in the future, what are their other medical issues, what stage were they diagnosed at, what are their individual preferences about treatment. So all this conversation then gets distilled down to what we would call a personalized treatment plan in oncology. So it is not quite a la carte where you go order what you want, but at the same time, that's being assembled for you based on the specifics that we study. And there is a lot today about shared decision making. So it is not just the oncologist throwing things at you, but in places where there are equivalent options, we need to involve women in the decision making and include them into the decision making process to be able to then offer what is the exact option that's relevant to that patient. That being said, the armamentarium is forever increasing. Of course, there is traditionally the surgery, chemotherapy, radiation, which we know of, but then there are these newer, in breast cancer, there's also endocrine therapy, and there's targeted therapy, and there's immunotherapy. And now there are therapies that are being based on your genetics of your breast tumor, as well as your inherited gene mutations. And so this is a forever evolving space where it's hard even for one individual to keep up with how much data that keeps getting, added to this space.
Yeah. I remember when my mom was going through it, the big question we had to answer was, well, is she going to be open to immunotherapy? I'm like, what is that? And so, and I think, like you said, it's evolving so fast that even to get the right advice very often is not easy.
It's not. And I think it's, yeah.
It's a whole topic.
Yeah.
The therapeutic part, I think, is a whole, conversation in itself.
But, largely you have to get comfort in the fact that therapies are getting better, more effective, getting to be, there is less side effects from each of these things. So when it even comes to surgery, we're offering surgeries which are combining plastic surgery with your breast surgery to make it aesthetically not, something that a woman has to now live with scars and deformity or a lost breast. We are no longer practicing in that era. We are with so many patients that can avoid chemotherapy altogether because of certain tests we do on their tumor samples. So radiation has gotten to be more precise. So therapies are getting more accurate and better tolerated, and we're continuing to make progress. So there's each day a better day when it comes to that.
All right, I'm going to jump to the questions, Pranjali, and I'm going to go through the ones that we actually were sent beforehand on the community, and then I'll go through the ones on the community. We'll try and do it quick fire. How safe are these tests in terms of radiation exposure?
So mammography is really, misunderstood. Like people talk about, oh, there's radiation, so I don't go for a mammogram. And, your probability of your life getting saved because you had a mammogram that picked up a cancer 1 or 2 years before you would have felt a lump is way higher than any theoretical risk of radiation. And you have to realize that radiation from mammography is actually very low dose radiation. These are X-rays. They're not any, other type of radiation. And that level of radiation is quantified as the same amount of radiation that you get from background radiation from the earth. So we live on earth, which is emanating some degree of radiation, or a transatlantic flight will expose you to the same amount of radiation as a mammogram. So
yeah, exactly. Is the hereditary breast and ovarian cancer more aggressive than the somatic nature of any types of cancers?
So what has been seen in the BRCA mutation carriers is that the simply having the BRCA mutation doesn't make the cancer prognosis worse, which means your likelihood of having good outcomes and good survival is dependent on the type of tumor that you have and not the fact that you have a BRCA mutation. That being said, especially in BRCA mutation carriers are at a little bit higher risk of having triple negative breast cancers, but again, triple negative breast cancer, BRCA mutation versus non-BRCA mutation, the outcomes have shown to be the same.
Are there any pathogens, virus, bacteria, fungi involved in breast cancer like HPVs in cervical cancer?
Interestingly, HPV has been found in some types of breast cancer and some types of breast diseases as well. But no, it is not. We don't implicate, larger external pathogens in breast cancer. Although they may be found around them, they may not necessarily be causative.
I mean, the next one I think I can answer. There were questions about Pilates and cycling. Are they good forms of exercise? Absolutely. Anything that increases your heart rate is great.
Any exercise that you continue to do is good. Please keep doing
it. Do you consider stress as a cause of breast cancer?
Stress is more like a part of human evolution. I don't think there is ever opportunity to eliminate stress. At some point I'm reading Yuval Noah Harari's books to my children now. And I realized that, at some point stress was having, a tiger chase you through the jungles. And now it is your taxes. So there is no human living without stress. So it's very hard to quantify and implicate, much like everything else. But
I mean, I've seen studies that talk about, stress causes cortisol. So there's a mechanistic view on it, but there is
and a lot of it is association, right?
Yeah.
Like women often will ask, well, I had a divorce last year and now this year I got breast cancer. Did that cause it? Just because it got associated in the timeline doesn't necessarily mean it caused it.
Yeah. There's a question. My mom passed away due to cancer in her 40s and no one else in the family has had cancer. How often should someone like me have a mammogram? Is an ultrasound okay and should HRT be avoided? I have at the moment not done BRCA testing.
So we usually look at, a patient who's had a mom diagnosed at the age of 40 or below. You do have a slightly higher risk of developing breast cancer. So definitely start screening mammography. If your mom got diagnosed at 40, I wouldn't ask you to wait till 40 to start screening. You can be offered screening starting the age of 35 and doing it once a year. I would not replace mammography with ultrasound because ultrasound is not the recommended screening test, although it can often be used as a complementary test to then add on to the mammogram after. And if there were a known genetic mutation in your mom and then you got tested for it, and if you were a carrier, then there is definitely more guidelines available to where we can add MRI into the mix. We discuss preventive surgery. Now, the difficult part here is if you've lost a family member and they're no longer available to where we can genetically test them, but if they met criteria for testing, so if they had a triple negative breast cancer at the age of 40 and were never tested, I would not deny their children testing. So,
Yeah.
but they have to undergo appropriate counseling before they do so.
And a follow-up question to that was, should HRT be avoided for a person like this?
No, not necessarily, not unless, usually what we recommend is come in for your baseline exam. Let's look at your baseline first mammogram. Let's quantify the risk. Let's look at if we have old records of what type of tumor it was. So this is more formulating an individualized screening plan, and that would be done based on evaluating some of these factors.
Yeah. And by the way, I think the point I made about the Women's Health Initiative, that is the one that started spreading this thing about HRT causes breast cancer, and that just messed up the landscape. Should mammograms be done annually even after the age of 50?
So, a lot of confusion was added because of the USPTF changing its guidelines a few years ago, and all the other societies kind of refuted them, the American College of Surgeons, the American College of Breast Surgeons. Now, what I will tell you is the guidelines that I ask women, and of course, we're not a population-wide screening population here, but in India, we see breast cancer at a much earlier age compared to the West. So our peak age of incidence of breast cancer in India is 48 to 52, and that's a decade later in the US population. So whatever, even if the US did at some point change its guidelines and it said, let's do it after 50, let's do it once in 2 years till 50, and then let's do it once a year after 50. In India, we've sort of stuck to recommending to women that start at 40, because it's too late by the time if you start at 50 and 55, it's late. And so start at 40 and repeat once a year. And even after 50, it continues to be once a year. And you do continue to screen. There is no recommended stopping age of screening. So as long as the patient is able to undergo treatment for an early detected cancer and they're well enough to treat it, there is no particular recommended stopping it. So we have some women who continue to screen well into the 80s because they're healthy enough.
I'm going to modify the next question, Pranjali, because I know you and I have had a conversation about this. This whole thing about interpreting by a radiologist different images. And this question is about medical imaging AI, and is that there yet, and all of that. And I know you have a view on this. You want to talk about it?
So, compared to, let's say, going for a hemogram or a HbA1c or a lipid profile, which across labs, largely the reporting remains standardized. A lot of reporting when it comes to breast imaging, whether it is mammography, whether it is ultrasound, comes down to the expertise individual observer reporting the test. So it's not like you go through a mammogram, at the end of it, you get a little slip with the report. There's a radiologist who is actively studying those images and are supposed to evaluate it and compare this year's mammogram to your previous mammogram. Look at your prior biopsies that you may have had, prior surgeries you may have had, and then derive a report, which usually then gets reported as, in various what we follow is something called as a BIRAT score, which is given at the end of your mammogram. And the usual recommendation is anything BIRATs 4 and up is advised a biopsy confirmation. Now, what we end up seeing, at least in India especially, where breast imaging is not very well developed, especially when we look at average community radiologists who may not have had as much experience, there's a lot of false negative reporting that happens. And I feel like, at some point, AI is already part of, a lot of equipment that is coming out. There's a computer-aided detection systems that are already being used in interpretation of mammography. There are your tools of mammography interpretation will guide the radiologist. Hey, look at this area better. But I'm really hopeful that it will, decrease the error rates of the average mediocre radiologist. and that's not to insult anybody. I'm just saying that if you don't have adequate volume in reporting, I'm hoping that the AI tool, which has more access to more data, will make you less error prone. And whether we like it or not, that's going to be there.
Yeah, makes complete sense. Maybe the last question, because we're out of time. Is premenopausal breast cancer more aggressive than postmenopausal breast cancer? If yes, what are the reasons?
So it just so happens that in premenopausal or younger women, for that matter, we do end up seeing more high-grade tumors, more likely to find triple negative or receptor negative tumors, and that's just the biology of the disease itself. But when we compare subtypes of the tumor itself, so if you would, the age per se is not necessarily an independent predictor of worse prognosis. So just because you were diagnosed at young age, if you had the same kind of cancer and you got the same kind of treatment, doesn't necessarily mean you will do worse, but you have a longer lifespan ahead of you to solve for. So a 5-year survival, doesn't mean the same thing in a 30-year-old compared to a 65-year-old, because the implications of that.
Right. Radiation after effects, hair loss. Is it possible for this to resurface a few years later?
Usually chemotherapy is the one that causes hair loss. Radiation, especially when it comes to breast radiation, well, maybe brain radiation is different, but breast radiation doesn't cause hair loss. So it's chemotherapy-induced alopecia. In majority of cases is reversible, and the hair does grow back by the time you've started radiation, really.
Perfect. I think that's about it. I mean, there are a few more, but I think we're running out of time. So Pranjali, thank you so much. I mean, this was really, really informative, not surprising, but always fun to have conversations like this. And I think at least I learned a lot, and I'm sure everyone else did as well. So thanks. And maybe in a few
It's a
months,
pleasure being here. And, if anybody has any other questions we haven't answered, I'll be happy to take them later as well. Feel free to reach out. I'm pretty easy to find and reach out.
Yeah. And so so everyone knows, Pranjali, you're primarily at Jupiter, right? That's where you...
Yeah, I do all my breast cancer surgeries at Jupiter Hospital in Pune. And I also have a private breast clinic called Pune Breast Care, which is in Deccan and Pune.
And then the one last thing I would say is Pranjali is one of the co-founders, along with Nikhil and Mitali, of iShare Foundation. And I know, Pranjali, you do a lot of talks to help build awareness all over the place. And so if any of you ever want to learn or hear any of Pranjali's talks, I'm sure there are enough of them all over the place on YouTube and everywhere.
Yeah.
Yeah. But yeah, thank you again, Pranjali, and I hope everybody else had a great time and learned a lot.
Well, I had a great time too, Nikhil, and thanks for making this part of the conversation for the community and giving the due importance this topic definitely deserves. So thank you so much for taking that up.
Great. All right, lovely. Bye, Pranjali. Bye, everybody.